Good evening, everyone. Today we are having yet one more session of Odyssey or OSCE series by IAP Kozhikode and IAP Kerala. Today we have a very interesting topic. The topic is on immunocompromised child. So basically, it's a vast topic. It contains lot of from primary immune deficiency to secondary immune deficiency, and since there are a lot of changes happening in the treatment of HIV, our speaker today, Dr. Geeta ma'am, she has opted to take HIV in a child and how to manage a child with HIV exposure. And I would like to introduce our speaker, Dr. Geeta Govindraj ma'am. Ma'am is a professor of pediatrics in Government Medical College, Kozhikode, and ma'am has a lot of publications in primary immune deficiency and has been one of the leading speakers on the topic primary immune deficiency in the South. I would like to welcome our speaker Geeta ma'am and to start off the sessions directly.
Thank you, Dr. Ajay, for that very kind introduction. And I would also like to say thank you to IAP Kozhikode and IAP Kerala for giving me this opportunity. So what has happened over the last decade and a half in management, diagnosis, and care of HIV exposed and infected children, and more importantly, in prevention of HIV infection from infected mothers to their babies, has been a huge revolution, which I think has not been celebrated enough. The problem, however, for our postgraduate students is that although we do not see HIV positive children now, and they're not becoming, we haven't had a positive child born to an infected mother in spite of prophylaxis with ARV in the last 5 years in Kerala. But the huge problem is that these questions are still liable to appear in the exam paper, in the theory, as well as they are OSCE and clinics that can be asked. Okay, so I just remembered this adage by G.K. Chesterton, who said that fairy tales don't tell children that dragons exist. Children already know that dragons exist. Fairy tales tell children that dragons can be killed. So this again reminds all of us that what is possible. So it's a huge success story. So let's go over to the OSCE proper now. So in the next few minutes, I aim to finish in about 45 minutes. We'll have questions on prevention of parent-to-child transmission, early infant diagnosis, feeding of HIV-exposed and HIV-infected infants, cotrimoxazole prophylaxis, immunization, antiretroviral therapy. And a lot has happened in antiretroviral guidelines that we all must know. Dolutegravir is now a first-line antiretroviral drug. And we'll also have a few questions on opportunistic infections. Okay, so let's go to question 1. And I hope that this can be as interactive as possible. I'm sure Dr. Ajay will do the needful to make it so. And I wish all our residents who have joined would actively participate in the discussions and answer the questions. So the first one, you have a 1-month-old baby.
Excuse me.
Yeah.
I will ask the participants to answer in the chat box.
Yeah, please do. Dr. Ajay, you can instruct them.
Yes, ma'am. All the participants, please do it like a Viva. Do it like a OSCE session and put on your answers in the chat box. We'll see how much correct you can get and you get actually involved, like Madam said. So we'll go with the OSCEs, ma'am.
Okay, right. So first one, we have a 1-month-old baby born to HIV positive parents at term. Okay. And this 1-month-old baby of retropositive parents is on exclusive breastfeeds and never up in prophylaxis. Okay. That's what we used to do. The parents are, however, anxious to know whether the baby is infected or not. Question 1, what is the preferred test and why? Answer?
HIV DNA PCR, somebody has mentioned.
Right, right. And why?
Why nobody has told, ma'am?
Yeah, we'll come to that later. How long should they wait to do this?
18 months, somebody has mentioned. 6 weeks, up to 6 weeks.
Yeah, 6 weeks is the right answer. How long should they wait? Are repeated tests needed? And if so, when? So when will we repeat the test?
18 months, somebody has mentioned.
Yeah. So after 6 weeks, we will repeat the test at 6 months. Now the guideline says do it again at 12 months and then the confirmatory test at 18 months. Okay, we'll go through that. And when can the baby confirm to be HIV negative? I think lots of them have already been talking about that at 18 months. Enumerate 3 precautions to be taken in the labor room to prevent HIV infection in the newborn baby. Anybody? 3 precautions in the labor room to prevent HIV infection in the newborn baby.
They mentioned prevent invasive procedure, do not do ARM.
Right, right.
Limit PV, cesarean preferred.
Excellent. Cesarean preferred, the answer would be cesarean only for obstetric indications. Right. I'm glad you said that. So just see the next slide. Why you have to do an HIV DNA PCR at 6 weeks. You can see the sensitivity is 98% and the P24 antigen much less sensitive. Okay. An HIV antibody can be false positive up to 18 months. And HIV viral culture, of course, takes a long time, very expensive, not readily accessible. Okay. So these are the guidelines. All HIV exposed babies will be tested at 6 weeks by HIV PCR. And if the baby is PCR positive by the first dried blood sample, a second DBS will be collected for confirmation. So you need to do 2 serial tests if the first one is positive. If the baby is confirmed positive by 2 PCRs, then start ART. The PCR negative babies at the first visit, followed up by antibody tests at 6 months, all 3. And if anyone is positive, you have to do the dried blood spot. Again, at 12 months, we repeat the antibody test. Dried blood spot sample is also collected. And if antibody test is positive, then DBS will be sent for PCR. 18-month antibody testing, irrespective of previous status on PCR or ART, has to be done mandatorily. And this is the EID algorithm. You can all see clearly at 6 weeks, collect DBS. Okay. If it is positive, again, repeat for a second test. 2 tests positive, start ART. Okay. If it is negative, again at 6 months, do the antibody test. If any antibody test is positive, that would require, again, a dried blood spot sample. So the guidelines are very, very clear as per early infant diagnosis. Previously, the poor parents had to wait for 18 months, but now they get a diagnosis much, much earlier and it improves the follow-up. So this is the first answer. DNA PCR on DBS. When? At 6 weeks. When next? 6 months, 12 months, 18 months. Confirmatory test at 18 months. And the other procedures, avoid milking of the cord. Don't do delayed cord clamping. Ajay, there is a problem. There is somebody who is unmuted. Then avoid suctioning and invasive fetal monitoring. Now, let's go to the second question. So you have Anu and her husband Arun, who have been on ART for the last 5 years. She is pregnant with their first child and is at 36 weeks of gestation. The couple are anxious regarding breastfeeding the baby. The questions are, can she breastfeed the baby? Answer, yes or no?
Yes, mentioned, ma'am.
Yeah, great. If so, can she add formula feeds if breast milk is not adequate?
No.
Yes. No is correct. When can complementary feeds be initiated? Answer is
6 months, ma'am. 6
correct.
months.
Yes. Excellent. So I think everybody, lots of people are answering, or one person is answering all the questions?
No, ma'am. A lot of people are answering.
Multiple people. Great. Yeah. Last one. How long is breastfeeding recommended in this child?
One year. Some people are told 6 months, 2 years.
Okay. So they're all right in a way. So well, let's see the national guidelines first. So exclusive breastfeeding for the first 6 months with lifelong ART in any situation where we can guarantee that ART will be taken, reliable supply and counseling for the parents, then okay, you can give exclusive breastfeeding. No change in guidelines for HIV exposed or unexposed infants. So the feeding guidelines are same as for any child. So the answer for the last question was at least breastfeed for 12 months, but can extend up to 2 years, like in any other child. Breastfeeding is made safe by giving ART to the mother and ARV prophylaxis to the baby. We'll see later. So introduce complementary feeds after 6 months. Stop breastfeeds only after an adequate safe diet is assured. And breastfeed, as we said, at least 12 months, but can be continued up to 24 months or beyond, as in the general population. So very happy with your answers. Now let's go to the third question. Here we have a 30-year-old lady who is found to be HIV positive at 35 weeks gestation. Okay. She plans to give exclusive breastfeeds because the family is unable to afford replacement feeding. Okay. Not uncommon situation. Okay. So one good thing that has happened is the counseling is happening before delivery, not in the labor room after she has delivered. So the questions are, what regimen will you use for infant ARV prophylaxis?
Nevirapine, mentioned, ma'am. Nevirapine, Sidobudin.
Okay, right. So nevirapine is right as far as we were doing, but we have a new guideline which I'll be sharing with you. That's why I think somebody has said zidovudin as well. Let's see. How long should it be continued?
12 weeks.
So again, up to 12 weeks, if the mother is giving exclusive breastfeeds and has not had at least 6 months of antiretroviral therapy. Otherwise, up to 6 weeks. We see the guideline. What investigation is recommended for the mother?
CD4 count somebody is mentioned.
Okay. So according to the new guidelines, the mother has to have a viral load estimation between 32 and 36 weeks of gestation to decide on ARV prophylaxis. But this lady, she's been found to be positive late in pregnancy, only at 35 weeks. Therefore, we will classify this infant as a high-risk infant. I'll show you the guidelines. So is there any difference if the mother is HIV-2 positive or dual HIV-1 and HIV-2 positive? A little difficult, but let's see.
Low risk for infant.
Yeah.
HIV-2 Sidobudin has to be given.
Correct. Exactly. So, neverapine, the NNRTIs have no effect on HIV-2. And therefore, you cannot use neverapine prophylaxis if the mother is either HIV-2 or dual HIV-1 and HIV-2 positive. So, let's just have a look at the updated guidelines. So, according to the new guidelines, a viral load has to be done for the mother between 32 and 36 weeks of pregnancy. And if the mother's viral load is not done or she is not virally suppressed, that is, her viral load is at what level? Anybody? When will you say viral load is not suppressed? If the viral load is more
less than 1,000, somebody is mentioned.
Yeah. So if it is 1,000 or more copies per ml, then she is not virally suppressed. Okay. And if she is newly diagnosed, as this lady is, or not on ART, then that's a high risk infant. And if the infant is high risk, that is, if any of these criteria are met, then you have to give dual prophylaxis. That is, neverapine plus syrup zidovudin for 6 weeks if the baby is on replacement feeds. And if mother is exclusively breastfeeding, you have to continue for 12 weeks. And if syrup zidovudin is not available, you have to use syrup lopinavir ritonavir after 14 days along with syrup neverapine. I think that is clear. In some centers, zidovudin availability is an issue. So if you can get only neverapine syrup, go ahead with that, even if the baby is high risk, and add lopinavir ritonavir syrup after 2 weeks along with neverapine. So we have now, again, looking at the guidelines, infants of women with prior exposure to neverapine or born to women with HIV-2 infection should be given syrup zidovudin in place of syrup neverapine. So infants of women with prior exposure to neverapine in their previous pregnancy or those born with HIV-2 infected mothers have to be given zidovudin in place of neverapine. No use of neverapine at all. And the dose of neverapine we use, it's once daily dose. No need to worry about the dosage, but just for information, if it's more than 2,500 grams, we give 15 milligrams OD. Between 2000 and 2500 grams, 10 mg or 1 ml OD. And the dosage of zidovudin syrup, it depends on, again, the birth weight, and you can see it is given twice daily. Okay. So it will be 5 mg, 10 mg or 15 mg, depending on the birth weight. So the answers to the third question, what regimen? Neverapine and zidovudin because it's a high risk infant. How long? 12 weeks because she is exclusively breastfeeding and is not had antiretroviral therapy for an adequate amount of time. What investigation is recommended for the mother? Well, viral load, not just CD4 count. And is there any difference if she is HIV-2 positive? Then no neverapine, only zidovudin. So I think that is clear. So now let's go to the fourth question. Okay. So here you have a 2-year-old asymptomatic child who weighs 9 kg. And this child is found to be HIV positive. She has a normal complete blood count and a normal CD4 count as well. Her TB workup, renal and liver function tests are all normal. So no evidence of tuberculosis. Now, the questions would be, what treatment should be initiated? Anybody? What treatment should be initiated? So maybe we'll get answers later. Okay. Will it be a PI-based regime, protease inhibitor-based regime, or an NRTI-based regime? Okay, we will see that later. What steps should be undertaken initially? Anybody?
They mentioned PA based.
Excellent. That's right. And what steps should be undertaken initially before you start ART? So ART is a lifelong commitment, isn't it? So what steps should be undertaken initially? You are starting ART for a 2-year-old asymptomatic child, remember.
LFT counseling.
Yeah. So agree that somebody has thought of counseling. So you have to identify the caregiver. You can't have the same tablet being given twice to the child by different caregivers, isn't it? And what is the 4S symptom checklist for TB screening? So everywhere you can hear about the 4S symptom checklist. So it's nothing. What is it? Very simple. The 4S symptom checklist. So it only means that we ask for current cough, not cough in the last 2 weeks as we would in any other child. Current cough, fever, poor weight gain, and contact with tuberculosis. This is the 4S symptom. That is the screening checklist. And what drugs, if any, are required for prophylaxis for this child? What drugs, if any? What prophylactic drugs would we give to this 2-year-old child?
Cotrimoxazole.
Exactly. And one more. So TB workup is normal. So you will also give?
Azithromycin.
Okay. So anybody IPT, INH preventive therapy is also mandated. So let's see the answers. So you have antiretroviral therapy with PI based, as you said, abacavir, lamivudine, and lopinavir, ritonavir. Okay. Then informed consent from the caregiver, explanation, planning. You have to show them the syrup, tell them when to give, how to give it, what to do if the child vomits, how to set reminders, how early a reminder is required, at least half an hour, isn't it? So these are the things. And before that, just go through this important slide. So you have to confirm HIV infection. After that, if the age is less than 6 years, you will go with the ALL regime, and 6 to 10 years and 20 to 30 kg. Okay, not or. The child is 6 to 10 years old and weighs more than 20 kg and less than 30 kg, then it would be abacavir, lamivudine, and dolutegravir. That is the new regimen. Sorry. And if the child is more than 10 years old and body weight is more than 30 kg, then you will give a TLD, the tenofovir plus lamivudine plus dolutegravir. So tenofovir is given only if the child is above 10 years and weighing more than 30 kg. If the child is 10 years old but weighs only 20 kg, then you cannot start tenofovir. So I think that is clear. Next one, question 5. So you have a 9-year-old girl who is rescued from a child lifter and she has tested HIV positive. Okay.
Madam,
yeah.
The last slide, people just want to see, few people just want the last slide once more.
Once more. Okay.
Can you bring it down, because lower part they cannot see.
Yeah, I'm not able to do that.
Man, just like come from the slideshow. Yeah.
Oh, I cannot do that.
Okay, ma'am. Not seen, but it's okay. We'll proceed.
I will just say it again. So less than 6 years, body weight less than 20 kg means you have to give a regimen with ALL, abacavir, lamivudine, and lopinavir, ritonavir. Just remember ALL. Okay, so that is a PI based regimen. Less than 6 years, less than 20 kg. So next one, 6 to 10 years and 20 to 30 kg. Then it is ALD. So abacavir plus lamivudine plus dolutegravir. Then age more than 10 years, body weight more than 30 kg. Then it is TLD. Tenofovir plus lamivudine plus dolutegravir. Okay, I'm sorry about that slide. So let's go to the fifth question. Here you have a 9-year-old girl rescued from a child lifter, and this girl has tested HIV positive. Unfortunately, she is febrile and has been diagnosed to have sputum positive pulmonary tuberculosis by CBNAT. So she has two problems now. The most common opportunistic infection with HIV positive children is tuberculosis, and this girl has this opportunistic infection with HIV infection. Her CD4 count is 250 per cubic millimeter, that is low, and her SGPT is normal, 20 milligram per deciliter. So what ART regimen will you start? So there is no doubt at all that this child has to be started on ART. And before that, just like to remind everyone that any HIV positive child, whatever be the CD4 count, whatever be symptoms, asymptomatic, whatever, a diagnosis of HIV positive HIV infection means starting antiretroviral therapy. That's how it is now. Okay. So what will be the ART regimen you will start? So we are already seen the girl is 9 years old. Okay. She, okay.
ALD.
Okay. So if her weight is more than 20 kg, you can start ALD. Okay. Then what anti-TB regimen is recommended? What will be the anti-TB regimen you will give? That is category 1, isn't it? We'll come to that. What will be the sequence and interval between the treatments? Here there is a difference now. New guideline says a different recommendation. Anybody? Which will you start first, ART or ATT?
ATT.
Exactly correct. So the opportunistic infection is the emergency, not starting ART. Interval between ATT and ART, what is the interval recommended now?
2 weeks.
Exactly correct. Within 2 weeks. So that is a change in the guideline. Previously, we used to say up to 8 weeks. But now, if the child is having pulmonary tuberculosis or any other extrapulmonary tuberculosis, start within 2 weeks as far as possible. The only exception is if the child has tuberculous meningitis. In that case, so you have to start a little later, between 2 weeks and 8 weeks. Any other drug that will be prescribed?
Pyridoxine and cotrimoxone.
Exactly. Correct. Very correct. So here, I'm just showing you how you change the ART regimen based on when you give a rifampicin containing ATT. Okay. So in children, we are not giving rifabutin. It's not recommended below 12 years. So we are giving rifampicin based antituberculous therapy. So if you are giving a dolutegravir based regimen, you have to double the dose of dolutegravir. So instead of giving once daily, you have to give twice daily and do it for 2 weeks until after the last dose of rifampicin. Okay. If it is LPV, lopinavir, ritonavir based regimen, you have to super boost. That means you have to give lopinavir, ritonavir not in the usual ratio of 4:1, but super boost as 1:1. Okay. So dolutegravir becomes 50 mg BD. Okay. So we are not giving a dolutegravir, lopinavir regimen. We will be starting soon in younger children. Dolutegravir now is given only in children above 20 kg, but the US recommendation, the FDA recommendation has come for children as small as 1 month. So when we get formulations, the program is going to include dolutegravir for younger children soon. Okay. So this is the answer. ATT regimen, CAT1, 2 HRZE plus 4 HRE. Start ART within 2 weeks. ART regimen, ALD, correctly said. Twice daily dolutegravir, continue 2 weeks until after stopping rifampicin, and rifabutin not recommended for children under the age of 12 years. Question number 6. A 6-week-old baby is born to HIV positive parents and is seen in the immunization clinic. BCG was not given at birth. Parents are both stable on ART. Elder sibling is aged 8 years and is asymptomatic on ART, but has not had viral load estimated recently. Okay. So the questions, first question, what vaccines will you give the baby? Answer. Will you give BCG?
BCG, Dr. Pawan has told.
Yes, exactly right. So India is a high TB burden country, not really a high retroviral HIV burden country. And at birth, the children are unlikely to be symptomatic, and they're not, we don't know yet whether they're infected or not. So BCG should be given at birth and at 6 weeks as well if it was missed at birth. Okay. So will you give rotaviral vaccine at 6 weeks? Yes or no?
Yes.
Yes, exactly. Again, the answer is yes, because the risk is more of the baby acquiring diarrhea. And these babies are unlikely to be severely immunosuppressed at this age. So live vaccines are contraindicated only in severely immunosuppressed children. That is, if the CD4 count is less than 15%. Okay. So what are the 5 other? So killed vaccines, definitely we will give. And also oral polio vaccine. Except if the baby is severely immunosuppressed. Enumerate 5 other tasks to be done for this baby. What else should be done? What else will you do at this visit apart from immunization? 6 weeks. Anybody? Will you start any prophylaxis?
Anthropometry, somebody's mentioned. Nevirapine
Yes.
continue till 12 weeks.
Correct.
Cotrimoxol.
Correct.
DNA
Okay.
PCR confirm.
Excellent. Everybody knows everything, I think. So start cotrimoxazole prophylaxis. Send for the DNA PCR. Assess growth parameters, as you said, by anthropometry. You also have to check mother's adherence to ART. Ask her if she has any breast condition. And you can, in addition to asking whether she has any breast condition, you can assess positioning and attachment and perform a full examination of the baby to make sure that there are no treatable medical conditions. Okay. Will you prescribe IPT for the elder sibling? The answer is what? Yes or no? Quickly. Elder sibling, asymptomatic, 8 years old. Only thing, no viral load. Will you give or yes or no? IPT is INH preventive serum.
Few people told yes, few no, ma'am.
Okay, so the answer is yes. The only contraindications to IPT are if the child has tuberculosis or if the child has peripheral neuropathy, or if the child has hepatitis, or if the child is an MDR TB contact or has been treated for MDR TB himself. Okay. Any drug which is prescribed along with IPT? Any drug prescribed along with IPT? Well, the answer is, I'm sure you will say B6 or pyridoxine. What is the frequency of viral load estimation for a child on ART? So a child stable on ART, is it enough if you do the CD4 count periodically, or should you have viral load estimation? If so, how frequently? Anybody answer? Ajay?
Only if symptomatic.
Oh, well, that's not exactly right. So the viral load would be estimated 6 months and 12 months after initiating ART, and after that annually. That is the recommendation. Okay. So these are the answers to the question. We have already discussed this. Now let's go to question 7. This is a very simple one to match the following. Sometimes you do have a little more complicated match the following, but this one is a little simple. So all you need to do is match the drugs which are there on the right side with the categories of drug on the left side. Okay. And second part, write 4 reasons why dolutegravir has been included as a first line antiretroviral drug. Okay. So let's try. Ready? Okay. So which one is the PI here? Protease inhibitor. Anyone?
B.
Is it B? Somebody said?
Yes, ma'am.
No, the answer is
E.
E, correct. Atazanavir. Right. Next one, which is the integrase inhibitor? Integrase inhibitor is?
C.
Correct. Which is the non-nucleoside reverse transcriptase inhibitor, NNRTI? Answer is?
D.
Answer is A, actually. Now, efavirenz, isn't it? So nevirapine and efavirenz are the NNRTIs. Which is the NRTI? The nucleoside reverse transcriptase inhibitor. NRTI. So you have azidovodin, stavudin, lamivudin. These are all NRTIs.
B.
There is one. D, correct. Abacavir. Abacavir, although it sounds like a protease inhibitor, abacavir is in the category of NRTI. And lastly, which is the nucleotide reverse transcriptase inhibitor. Not nucleoside, but nucleotide reverse transcriptase. Correct. Tenofovir. Okay. So write 4 reasons why. Tell us 4 reasons why dolutegravir is included as a first line ART. Well, the answers are, the 4 reasons. One is delayed development of resistance to the virus. Okay. So delayed drug resistance, fewer drug-drug interactions, a better side effect profile, and a more rapid antiviral effect. Okay. So the viral inactivation is more rapid for dolutegravir. Okay. So here you have the answers: more rapid viral suppression, fewer adverse effects, less drug resistance chances there, fewer drug interactions, and the various categories and the drugs. So you did well. The 8th question. So we have only 10 questions coming to the end. So you have Paru, a 6-month-old baby. She is admitted with acute onset of cough and breathlessness. Examination revealed oral thrush, cyanosis, chest retractions, and scattered crepitations on auscultation of the chest. Her HIV ELISA is positive. So we said we would do the antibody test first before doing the dried blood spot PCR at 6 months also. So the questions are, what is the most probable diagnosis here? Anybody?
PCP pneumonia.
Exactly correct. So here you have a child, severe respiratory distress, cyanosis. So the characteristic thing is your chest signs, crepitations will be much less prominent when compared to the degree of cyanosis. Okay, so it is the most common opportunistic infection among HIV infected infants. How will you treat this baby? So what is the drug of choice? Pneumocystis jirovecii pneumonia.
Everybody's taking time.
They're thinking.
A Cotrimoxol.
Correct. So is it the usual dose or high dose? So we will come to that. And what do you observe on the chest X-ray? Chest X-ray. I think you can see clearly.
Interstitial pattern.
Yeah.
Lesion heal.
Correct. The perihilar infiltrates characteristically. Interstitial pattern is right. Okay. And how will you confirm the diagnosis? So it's a small 6-month-old baby. It's difficult to confirm, but is there any way you can confirm the diagnosis?
BAL.
Correct. Okay. You can do a BAL with induced sputum after nebulizing with hypertonic saline. So it's very difficult to do a bronchoscopy and bronchoscopic alveolar lavage, as you said, but an easier way out would be to get induced sputum with hypertonic saline and then stain with any of these stains, the Gomori methenamine stain or Wright's or Jamesa or Tolidin blue stain. Okay, so that only then you can confirm the diagnosis. But LDH, a high LDH value tells you that the disease is very severe, but it cannot confirm the diagnosis. Okay, so let's see the answers. As you said, Pneumocystis jirovecii, high dose cotrimoxazole 20 mg per kg per day, 6-hourly dosage for 3 weeks. Remember that you have to add steroids, oral prednisolone, if the SpO2 is less than 70%. So if the child can tolerate orally, give prednisolone. Otherwise, you will have to give IV dexamethasone. The dose of prednisolone, first 5 days, 2 mg per kg per day. Next 5 days, half the dose, 1 mg per kg per day. And then taper rapidly over two days and stop. Okay. So we've seen the X-ray findings, the induced sputum and the various stains. Another respiratory question here. This is the penultimate question. So we have an older child now, a 10-year-old HIV positive child who's presented with cough for the last 1 month. The child has cyanosis and clubbing and worsening findings on chest X-ray despite 3 courses of antibiotics, and TB workup, however, was negative. The question is, what is the radiological finding you see?
Miliary TB.
It does look like miliary tuberculosis, but see the situation. It is an older child, TB workup negative. So I agree that miliary tuberculosis would be one of the differentials here, but it is not the first diagnosis. Would be what? Anyone? Older child, longer duration of symptoms.
Aspergillosis, bronchiectasis.
No.
Histoplasmosis.
No. Yeah, fungal pneumonia would be a differential. So the answer is, anyone? It would be lymphoid interstitial pneumonia, LIP is the diagnosis. Okay, lymphoid interstitial pneumonitis or LIP. And if you have a child like this, what would be the clinical stage? Lymphoid interstitial pneumonitis?
3, 4.
3. 3 is the correct one. Okay. The diagnostic procedure of choice? You have already answered this in the last one. Bronchoalveolar lavage here. Okay. List 2 differentials. Again, you have already said lots of differentials. Fungal pneumonia, viral pneumonia, miliary tuberculosis. Other, you have a malignancy as a differential diagnosis, lymphoma, and also viral pneumonia comes under the differential diagnosis. Any two. How will you treat this condition? So is it an infectious condition? Will you require an antibacterial or an antimicrobial here? So what will be the treatment? Is it antibiotics, antivirals, or anything else?
Steroids.
Correct. Excellent. So the answer is you can give steroids. I'll show you the answer. So oral prednisolone, if there is chronic hypoxia, 1 to 2 milligram per kilogram per day, prolonged, long course of 2 to 4 weeks, and then taper to around 1 mg per kg per day for 4 to 6 weeks. Okay. So 8 to 10 weeks of treatment with oral prednisolone. In addition to that, nebulized beta agonists and chest physiotherapy. Okay. So you've been answering very nicely so far. And the last question, the simplest question I kept for the last. Categorize these clinical conditions as per WHO clinical stage. Very, very simple. Can you pick out the stage 1 condition here? Clinical stage 1. Which one?
B.
Correct. So persistent generalized lymphadenopathy is stage 1, asymptomatic or this. Then which is the stage 2 condition here? Stage 2.
TB.
No. Pulmonary tuberculosis is herpes. Pulmonary tuberculosis is stage 3 clinical. Okay. I'm sorry for the extra slash over there. Herpes zoster is clinical stage 2. So we have it here. PCP pneumonia is the stage 4 condition. Okay. So that's very simple. So the severe opportunistic infections and the organ involvement, like for example, if you have encephalopathy or nephropathy, cardiomyopathy, they are all stage 4 conditions. Okay. So this is very, very simple. So we have had very nice participation. So at the end of it, we just want to remember the SDGs. No child should be born with HIV infection. That is the aim. No child should die because of HIV infection. And no child should become an orphan because of HIV infection. However, the problem is these questions will be with us for more time to come. So we need to know this. We can't just say that in Kerala, now we don't have any more mother to child transmission and we hardly see any children in the ward. So you cannot say that you will not answer because of that. That's the entire problem. It's not really your fault. Okay. So these are the references. We have the new guidelines, National Guidelines for HIV Care and Treatment 2021, which just actually came out a few days ago. And the ART specialist induction course, very, very interesting. Okay. So thank you all for a very patient listening and a very interactive session. Thank you so much. And I promise that we will have a part 2 of the immunocompromised child OSCE along with the inherited immunological deficiencies. If Dr. Ajay and Dr. Mohandas and everyone else agrees. Okay.
Yes, ma'am. We'll surely do the next session, ma'am.
Okay.
And I would like to, on behalf of IAP Kozhikode and IAP Kerala, would like to thank Geeta ma'am for the excellent session. Topics are handpicked by ma'am specifically, and each question covers almost all part of HIV, including the latest changes. So excellent class, ma'am.
Thank you so much. You've been very kind, Dr. Ajay. So do you want questions in the chat box, 1 or 2?
Participants can unmute themselves if they want and ask any questions. I'll just allow it.
Okay.
And I think these questions are quite relevant for the exam and exam point of view also, because the latest guidelines have changed now. So you can expect 1 or 2 questions from this part.
So I hope the PGs who are going to write their exam soon have been listening. Okay. So
I think it's a very interactive session. Everybody answered.
Okay. So you have been a great host, Ajay. Thank you so much.
Thank you, ma'am. So we'll just stop the session, ma'am.
Okay. Thanks.
Okay, ma'am.